Welcome to Presentation 7 on Paying for Healthcare. I am dividing this presentation into two sections, the problem and the solutions, or potential solutions. The problem has two parts, the rising costs of healthcare and the uninsured. I am going to focus mainly on the former. The reason for this is that I am convinced by arguments from nonpartisan experts like the Government Accountability Office that rising costs are at the heart of the healthcare crisis. As far as solutions go, I want to look both at the Affordable Care Act, which passed recently, and some alternate systems, because no one expects that the Affordable Care Act will be the end of the healthcare debate or will solve all the problems we face. So in this presentation, I will be looking at the Canadian system and the Massachusetts system that was passed under former Republican Governor Mitt Romney, and comparing these plans to the Obama healthcare package which ultimately passed. I have also scanned readings on the Massachusetts and Canadian plans from the previous edition of the textbook that you are required to read. All of the problems we are experiencing with healthcare right now are being driven by a single cause, rising costs. Healthcare costs are rising much faster than inflation. For instance, in 2007, healthcare costs rose twice as much. A good way to think about this is in terms of GDP. GDP means gross domestic product. The GDP is the total amount of money that gets spent each year in America. It's the amount of money that was moving around. In 2006, 13% of all the money that was spent in America was spent on healthcare. That's about $2 trillion, and this is projected to rise to about 20% of GDP by 2016. This is important because it can bankrupt many important institutions in American life, starting with the federal government itself. Any institution that will have to pay for people's health care, large corporations, the federal government, state and local governments, all these institutions are confronting prices that are rising too fast to deal with. All of this was made clear by a report from the Government Accountability Office, or GAO, a nonpartisan part of the government that keeps track of how government money is spent and whether it was spent effectively. In 2008, the GAO produced a report called The Long-Term Fiscal Outlook. And the bottom line for the long-term fiscal outlook is that the government is going to be broke if healthcare costs are not controlled. This chart from the report breaks down federal spending into interest on the debt, Social Security, Medicare and Medicaid, and everything else. And here, everything else includes all the things we expect the government to do. Pay for defense, federal highway funds, the EPA, the NIH, all that stuff. All of these are represented by different shades of gray in the vertical bars. The black line is the estimate of how much money the government will take in, barring drastic changes in the tax code. What we see from this chart is that over the next 20 years, spending on Social Security, Medicare and Medicaid, and interest on the debt will crowd out all other spending, with Medicaid and Medicare accounting for the lion's share of the growth. As I said before, this is not just a problem for the federal government. It is a problem for the state and local governments and all big employers who pay for health care. This chart is also from the GAO report. The lines here represent the amount of money that the federal, state, and local governments have projected into the future until 2050. The dark line is the federal budget, and the dotted line is the combined budget for all state and local governments. As you can see, at the start of the century, all levels of government were running surpluses, but as time goes on, government at all levels will become increasingly in debt. In the past, people have been worried about rising Social Security costs as the baby boom retires. The GAO report emphasizes that while these costs will go up, they are not nearly as much of a problem as rising healthcare costs in an aging population. This next chart shows Social Security, Medicare and Medicaid costs projected out to 2080. As you can see, Social Security costs will go up, but they level off around 2030, while healthcare spending continues to grow radically. This chart is from the GAO website, but not from their 2008 report. It shows the composition of government spending in 1966, 1986, and 2006. In 1966, during the Vietnam War, defense was the largest component of federal spending. Medicare and Medicaid were only a tiny sliver, about 1%. Now, although we are fighting two wars, defense spending is about equal in size to Medicare and Medicaid. This is not because defense spending has gone down, but because healthcare spending has gone up. So, why are healthcare costs going up? Here's a list of 6 reasons, mostly drawn from Munson, although I have grouped some of Munson's things together. First reason costs are going up is the rising cost of drugs. As Munson emphasizes, the cost of drugs tripled between 1990 and 2000, and that's the way it has been going ever since. Drug companies justify the amount they charge for drugs by saying it is necessary to pay for all of the research that goes to make these wonderful drugs. Critics, including Marcia Angel, the former editor of the New England Journal of Medicine, argue that most drug research actually happens at universities and at the NIH and is funded by the federal government. This is the basic research which allows us to understand the cellular mechanisms that drugs are interacting with. Drug company research mostly just finishes up the public sector work, that packages work that has been done in the public sector as a product that can be marketed to doctors and patients. The other thing that drug companies spend a lot of time doing is developing small variations on existing drugs. For instance, when the patent on Prozac was about to run out so that you could get generic Prozac, the company that made Prozac spent a lot of money developing a time-release version of the pill. One that you would only take once a month. They could then market this heavily and continue to charge large amounts of money for Prozac, even though the cheap generic version was was now available. Okay, second reason costs are going up. It's the aging population. Prices go up as demand goes up. The law of supply and demand will reoccur frequently in this discussion. Well, demand for medicine goes up as the population ages. Right now, the first people born in the baby boom are now retiring, and this mass of retirees is just going to grow in the next few years. A third reason why costs are going up is that medicine itself is better. There are better technologies, there are better therapies. You can actually save people's lives. When you can actually save people's lives, people are more inspired to spend money trying to save lives. Demand goes up, costs go up. Also, the new technologies themselves are extremely expensive. A fourth reason why costs are going up, and this is emphasized by Munson, is the American style of dealing with medicine, which can basically be boiled down to aggressive treatment and not prevention. So the first problem comes when little money is spent on prevention. The next problem comes when aggressive treatment is mandated as soon as a disease manifests itself. So we could save money two ways. We could, one, focus on prevention. That'll save money. An ounce of prevention is worth a pound of cure. But also, when disease manifests themselves, we can wait to treat, rather than treating aggressively immediately, wait to see if the patient is really in trouble before jumping in with the very expensive tests and the very expensive treatments. A fifth reason why healthcare costs are going up is the aversion to rationing. Countries with national healthcare plans have national plans to distribute medicine. In the United States, we hate to say no to people. We hate to say to them, no, you can't have this treatment. It is unlikely to be effective enough to merit the amount we're going to spend on it. Now, of course, in the U.S., our resources are still finite, so we do wind up saying no. We do wind up rationing, but we ration in this backdoor fashion. We ration by ability to pay. Now, this means that people who can pay, either because they are personally very rich or because the government pays for their health care, will buy as much health care as they possibly can, increasing demand. Costs go up when demand goes up. This means that the people in the middle who can't pay for health care themselves but don't qualify for government aid are priced out of health care. So rather than rationing our resources based on need, we ration on the basis of ability to pay, and that means that large amounts of healthcare go to the very top and the very bottom. Finally, there are the problems with administrative costs. Oh, one other thing. Munson has a nice example here of an expense that we occur in America that would not occur in a government in a country that rationed healthcare. Heart transplants for people in their 70s. Right now, if you are wealthy and you can afford it, you can get a heart transplant even if you're in your 70s. Similarly, you might be able to dump that expense off on some government agencies. Rather than spending the money on someone in their 70s, that money could be spent on someone in their 30s. It could be spent on preventative care, and it would be simply much more effective. Okay, now on to administrative costs. 2003 study by the Harvard Medical School and the Canadian Institute for Health Information found that 31 cents on every dollar goes to administration. The reason we have such high administrative costs is that we have a large number of insurance companies that are all basically doing the same thing. Each one assesses risks, sets premiums, turns down claims, and designs and markets benefit packages. This is massively redundant. By contrast, in Canada, there is one institution that does this. It is the National Health Insurance Program. Munson ends this section by saying that some studies suggest that America could drop its healthcare spending by as much as a third simply by adopting the Canadian system. The effectiveness of U.S. healthcare spending. Well, if we're spending so much on medicine, are we getting our money's worth? Are we actually healthier? Munson has a nice section where he discusses this, and I'm just going to expand Munson's discussion here. Munson begins by comparing healthcare costs in 5 nations, the USA, Canada, France, Germany, and the United Kingdom. And what you see here in this chart and what you can read in Munson is that here in the U.S. we're paying about twice as much as the people in those other countries. Munson then goes on to talk about indicators of how good our healthcare system is and says that the U.S. comes out very low compared to the other 4 nations on that list. That is, we don't get as high quality outcomes as they do. I want to look in depth at two items here: life expectancy and the infant mortality rate. So the U.S., although we pay more for health care than any of these other countries, has the lowest life expectancy. Munson just mentioned that casually. I went ahead and tried to find and quickly tracked down the exact numbers. These are from a CDC press release. It's not a primary source, but it does confirm what Munson says, and it seems reliable. So our life expectancy is around 80, whereas in the other countries they are several years higher. Now, you can't immediately infer from this that our healthcare spending is wasted, because there are obviously going to be a lot of factors that drive down U.S. life expectancy. An obvious problem that we have that the other countries do not have is diet. Americans famously have very high rates of obesity, and obesity is associated with type 2 diabetes, with heart disease, and other things that shorten lifespan. So we couldn't simply raise our life expectancy by adopting a French-style healthcare system. We'd probably also have to adopt a French-style diet. Okay, another factor that we score badly on is the infant mortality rate. Here, the infant mortality rate is measured in deaths per 1,000 live births. So what they do actually is they count the number of children who died under the age of 1, and then the number of live births, and they set up the ratio that way. Well, as you can see, we're just in a whole other league than the other countries listed. All of their infant mortality rates are around 4 deaths per 1,000, and we are over 6 deaths per 1,000. Interestingly, a lot of this is driven by a radical disparity in quality of access to prenatal care. That is, for certain segments of the population have an even higher infant mortality rate. For African Americans and people in extremely rural areas, the infant mortality rate is more like 9 deaths per 1,000 live births. The other side of the problem with the healthcare crisis is the large number of uninsured, and this is actually the part of the crisis that gets the most attention. This comes from the feature that I described earlier, where some people can afford to pay for their own healthcare, some people qualify for government assistance, and then there's a vast number of people in the middle who are left uncovered by any kind of plan. And these are the people who suffer when healthcare prices go up. So it's estimated that 16% of the population go uninsured. It's about 45 million people. Munson further notes that the number goes up to about 60 million when you consider people who are uninsured for at least part of the year. It's also worth noting that 25% of the people who lack health insurance are children. The chart below is taken from the Kaiser Family Fund. They have a nice section on their website where you can just grab PowerPoint slides about healthcare. So this shows health insurance coverage in the U.S. for 2006. Most people get health insurance from their employer. Another section of people get health care from Medicare and Medicaid. A small number of people just buy it directly. And then the Kaiser Family Fund gives the same statistic that Munson gives. 16% of the population are completely uninsured. Okay, so the second half of this presentation is about potential solutions to the healthcare crisis. The first one that we're going to look at, and is also covered in your textbook, is the Canadian system. The Canadian system is also known as the Single Payer Plan. It is a national health insurance plan. actually a mandatory national health insurance plan. So some people might claim that it is socialized medicine. The Canadian system is not socialized medicine. Technically, it's socialized insurance. It is a national health insurance plan paid for by taxes. Supplementary private insurance is available for those who can pay. Also, people who can pay frequently just come to America and pay cash for elective surgery. We'll talk more about that in a second. Okay, this system has many important advantages. First of all, universal coverage. Everyone in Canada has access to health care and has roughly the access to the same basic level of health care that everyone else does. Furthermore, the Canadian system allows them to emphasize preventative care. The Canadians have more doctors who work as primary care physicians, as family physicians, as pediatricians, people in the front lines, rather than people who deal with exotic specialties. The specialists are people who you want to come in who once a strange disease has been identified. Right? And so this is the American style of healthcare, where you send in a highly paid specialist as soon as the disease crops up, rather than spending money on generalists who work with people on a regular basis to do just ordinary family physician type work. All right, two other advantages for the consumer. There's no paperwork for the consumer at all. You just show your card and the government works out the rest with the healthcare provider. There's also complete portability. Patients can see any doctor that they want. So there's no worry about having to look up what doctors are on your plan or going to the health insurance company's website, trying to find a doctor who says that they're on their plan, and then you call the doctor and he says, oh no, we're not really on the plan, the website's out of date, or I'm sorry, we're only taking patients in malpractice suits right now, or other kinds of lawsuits, right? You don't get any of that. The final advantage that is extremely important is the radically reduced administrative costs. A lot of paperwork gets eliminated when you don't have to do it 5 times for each insurance company. And notice that this isn't just paperwork for the insurance companies themselves. It's also paperwork for the healthcare providers who have to deal with, a half dozen different companies in the U.S., but only one company, the government in Canada. Well, there are drawbacks. And these need to be emphasized. The main drawback that gets a lot of attention are the waiting lists. Certain kinds of high-tech medicine, MRIs, for instance, have waiting lists. The United States has a huge number of MRI machines per capita, and if you can afford it, they will give you an MRI if you walk into the emergency room with a headache. Well, why not? You can pay for it, and then it might be something important. In Canada, you wouldn't get referred to an MRI, since the government has to pay for it, unless there's real evidence that you need it. And once you do get referred, you have to wait. You have to wait a long time because there are not as many MRI machines, because there's not a huge profit motive for every hospital to buy one. The other thing that has long waiting lists in Canada is elective surgery, things like hip replacement or knee surgery. In fact, these waiting lists are so long that basically anyone in Canada who wants a new hip and can afford to will simply come to America. The final drawback to the Canadian system is lower pay for doctors. In fact, Canada has a brain drain. Highly qualified doctors will choose to come to America to become specialists, where they can make a lot more money rather than stay in Canada and be general practitioners. The second solution that is considered in the Munson textbook is the Massachusetts plan. This is a plan for mandatory health insurance, but it's not always run through the government. So it's a combination of socialized health insurance and private health insurance. The main feature of it, though, is that it is mandatory. Now, this plan was supported by Governor Mitt Romney, a Republican, former presidential candidate, working with, I think, a Democratic legislature. It also strongly resembles the plan that Hillary Clinton put forward when she was running for president. So you have an interesting case here where both a Republican and a Democrat are putting forward a very similar plan. Okay, so what is the plan? It works like this. People below the poverty line are automatically put into a state-run insurance plan. So that part resembles the Canadian system. Everyone else is required to buy private insurance. The state helps people who cannot afford to buy private insurance by providing subsidies. This is, and the line here is 3 times the poverty level. If you make less than 3 times the poverty level, the state will help you buy health insurance. This system has one huge advantage: universal coverage. We saw in the previous PowerPoint that healthcare distribution was a justice issue. That is, you had to explain why it was fair for some people to have access to healthcare and not others. And if you took a Rawlsian approach to justice or an egalitarian approach to justice, you would find that there was no justification for saying that one person should get healthcare and another shouldn't simply because of the amount of money they make or, the amount of insurance they have. So the Massachusetts plan has one advantage. It solves the justice issue. Nevertheless, there are many problems with it. Munson mentions 2, and I want to mention a third. The first one that Munson mentions is that it is vulnerable to an economic downturn and is far more vulnerable than a single-payer plan. Basically, there's a lot of government expense here that is not offset by having healthy people paying into the government plan. Thus, if there's an economic downturn and a lot of people go on Medicare or go on to the government insurance plan, it could go bankrupt. The other problem is that many people feel that mandatory health insurance is a violation of individual autonomy. If you are young and healthy, you may think, I don't need health insurance. I'm going to be paying money and I'm going to be very unlikely to use it. This, for the government to require you to buy health insurance, is a violation of your autonomy. You might consider it a paternalist violation. For your own good, we're going to make you get health insurance. But honestly, it's actually a social welfare justification for violation of autonomy. The fact is that in order to pay for healthcare for the sick, you need the healthy spending money somehow. And one way to do that is to have them all buy insurance so the insurance companies can stay afloat and still pay for healthcare for the sick. My personal concern about the Massachusetts system is that it only contains weak measures to reduce costs. So if the driving force behind all of this is the rise in healthcare costs, you're going to need something that addresses that directly. The nation has spent the last few years embroiled in a heated argument about these issues, about healthcare reform. This is a debate that featured lots of crazy rhetoric, over-the-top talk of death panels and government takeover of medicine. And finally, on March 23, 2010, President Obama signed the Patient Protection and Affordable Care Act, which was supplemented 7 days later by the Healthcare and Education Reconciliation Act. All of this was in addition to huge amounts of spending on healthcare included in the federal stimulus package. So what exactly happened here? In the last part of the presentation, I will look at what we got out of all these efforts, and specifically whether it addresses the problems I lay out in the first part of the presentation, including problems with the Massachusetts plan, which it most closely resembles. So this year's healthcare plan looks a lot like the Massachusetts plan. You've got mandatory coverage from a mix of public and private sources. Specifically, everyone will be required to buy insurance or face a penalty. Those who make less than 133% of the poverty line will now be covered through Medicaid. Those who can afford to pay a little will get subsidies to buy private insurance. Now, the best way to think about all the complicated provisions of the Affordable Care Act is to divide them up into the provisions that take effect before 2014 and the provisions that take effect after 2014. So, starting before 2014, in many cases starting immediately, you can't lose your insurance if you become sick. Also, there will be a government pool, a high-risk pool, set up for people with pre-existing conditions. This is actually a temporary measure because, as we shall see, after 2014, insurance companies will not be able to turn someone down because of a pre-existing condition. They are also closing the donut hole, a gap in drug coverage for Medicare patients. There will be no co-payments on preventative care for new health care policies. That means that getting preventative care will cost the patient absolutely nothing, not even a $5 copay. And there will be additional Medicare payments for doctors who work in underserved areas. After 2014, everyone must have coverage. This is when the big shift comes. Everyone must have coverage, but states will have to establish insurance exchanges where companies compete to drive down costs and increase access. Exactly how these insurance exchanges will work has not been determined yet, but a very important part of them will be that companies in the exchange must offer a basic plan with standard benefits, and these benefits have not been specified. There will also be federal subsidies for people making up to 400% of the poverty line. You will as I said before, you will no longer be able to deny They will no longer be able to deny you coverage because of a pre-existing condition. They will also eliminate lifetime caps on payments. This is actually a really big deal, and Munson discusses the need for it in the textbook. The remaining co-payments for preventative care on existing healthcare plans must be eliminated, and a payment advisory board will be established to reduce Medicare spending. So this is a chart I grabbed from Wikipedia explaining the extent of the subsidies. Basically, if you're at the poverty line or lower, you're covered by Medicaid still. And then as you go up a certain distance from the poverty line, there is a cap on the maximum percent of your income that your health insurance payments can take up. So if you're up to 400% of the poverty line, which is like $90,000 for a family of four, your insurance premium can't be more than 10% of your income. And then there will be a subsidy that the government pays to directly to the insurance companies to cover the other part of your payments. So you'll be paying, for instance, if you're at $54,000 a year, you will pay $4,000, and then the other 72% of your premium will be paid for by the government. So does this avoid the problems of the Massachusetts plan? Well, it avoids some of them. Previously in the presentation, I cited 3 problems. And it was more vulnerable to an economic downturn, that mandatory insurance was a violation of autonomy, and the one that I was concerned with, that there were only weak measures to reduce costs. Basically, the 2 criticisms of the Massachusetts plan that are emphasized in your textbook go unaddressed in the Obama plan. So there's just nothing done to deal with the event of economic downturn, and you just have to accept the fact that mandatory insurance is a violation of autonomy. Or, yeah, you just have to live with that as an acceptable violation of autonomy if you approve of the plan. There is, however, a lot of measures in place to reduce costs. A lot of these actually came not with the main plan itself, but back in the stimulus package. Back in the stimulus package. And this includes a total of $21.6 billion for things like electronic medical records, prevention research, treatment coordination. And then the other nice thing that comes up is that in 2014, Medicare will begin changing the way it reimburses doctors so that they are not paid on the basis of the volume of their services, but on the quality of their care. And so this gets around the most fundamental problem with the growth in prices that we've seen over the last 20 years, right? Currently, we pay doctors for what they do, and so that gives them every incentive to do more and more and more, order more tests, order more procedures, even if they're not really necessary. If Medicare is unlinking payments to the number of services you perform, the number of tests you order, and instead links payment to how healthy the patient is, that should go quite some ways to reducing costs. Additional details about all of this are in your required readings. And this concludes video 7 on paying for healthcare.